Hello, I am doing my extra credit assignment on Chapter 34, Interventional Ultrasound, and this is for class 2405. So the objectives of this chapter, we're first going to define amniocentesis, chronic villi sampling, also known as CVS, and percutaneous umbilical blood sampling, or PUBS for short. We're also going to list the indications for amniocentesis, CVS, fetal tissue sampling, and endovaginal procedures. We're going to determine the correct gestational age to perform a genetic amniocentesis or a CVS sampling. We're going to describe the procedure for performing amniocentesis and CVS. We're also going to explain the differences between a transcervical and a transabdominal technique of CVS. And we're also going to list the invasive procedures that obtain tissue or blood samples from the fetus. Okay, first off, we're going to talk about amniocentesis. So what is amniocentesis? It is the sampling of amniotic fluid, and it's a common clinical technique for obtaining living fetal cells or fetal cell products from the pregnant uterus for prenatal diagnosis. And in the image here, you can see that the ultrasound, the transducer is on mama's belly, and they're inserting the syringe and the needle into the belly, into the amniotic fluid within the amniotic sac. And there they're going to sample that. So indications for amniocentesis. Well, maternal age-related chromosome abnormality risk increase after the age of 35. This usually results in the performance of genetic amniocentesis. So what happens when it's elevated or decreased? Well, what can happen is well, that's indication is elevated or decreased levels of the maternal serum alpha-fetoprotein. Also, indications could be lung maturity of the fetus, fetal infection, and isoimmunization status of the fetus as well. Alpha-fetoprotein and MSAFPS. Well, AFP, or alpha-fetoprotein, it's a serum protein found normally in the fetal circulatory system and produced by the fetal liver. Obstruction of amniotic fluid can result in accumulation of this protein in the fluid, and it appears as an increase in maternal blood. And it can show up in maternal blood. The circulating of the mom can increase as well. And then AFP elevations could result in the following: neural tube defects, ophaloceles, gastrocentesis, congenital renal disease, and esophageal atresia. So timing of amniocentesis. So when do you want to perform the amniocentesis procedure? Optimal time to perform it is between the 14th and 20th week gestational weeks. Adequate fluid volume will allow for obtaining useful samples with minimal threat to the fetus, and sufficient numbers of viable amniocytes are present to obtain. Performing amniocentesis earlier than 14 weeks has shown to significantly increase the risk for pregnancy loss. So the baby's more at risk of, the moms can lose the baby if you do it before 14 weeks. So the procedure now for ultrasound guided amniocentesis. So before we even start the protocol for amniocentesis, these are the things that we need to do beforehand. We need to find the number of fetuses, the fetal position, and the fetal viability. We also need to determine the amniotic fluid volume, if it's normal, if it's decreased or increased. We need to determine placental location. We need to assess the gestational age by the following measurements: your BPD, your FL, or your femur length, your abdominal circumference, your AC, your head circumference, HC, and your binocular distance. Also, we need to assess the cerebral ventricles, the four-chamber heart, the stomach, the urinary bladder, the umbilical cord insertion, the number of cord vessels, the kidneys, the spinal column, and the limbs. Basically just a normal assessment when you're going through your scan for the fetus. We also need to locate the optimal fluid pocket for amniocentesis, where it's largest and where we need to extract from. And you need to evaluate the fetal heart rate before and after the procedure. So now we get into the procedure itself. First, you need to drape the operative site with sterile towel. You need a sterile field. The ultrasound is then coated with regular transmission gel. And then under the sonographic visualization, we have a 3.5-inch long 20-gauge sterile disposable spinal needle with a stylet It's used to enter and insert into the amniotic sac. Amniocentesis is then documented with an image following. Discard. Then after that, we discard the first few drops of the fluid after removal of the stylet just for contamination purposes. Then we attach the 20-inch sterile flexible tubing to a 20 milliliter syringe. And then approximately we gather up to 20 to 30 milliliters of amniotic fluid, and we transfer it into a conical tube for transport to the laboratory. The needle is withdrawn after the aspiration, after we take the amount that we need, again the 20 to 30 millimeters of fluid, and then after that we check the fetal heart rate again to make sure the baby's okay. Now we get into chronic villus sampling. What is chronic villus sampling? Chorionic villus sampling, CVS. It's the sampling of the chorionic villus of the placenta. It's a safe and effective sampling of the first trimester living trophoblastic tissues needed for genetic diagnosis. It allows the use of increasing number of tests for biochemical and molecular disorders of the fetus, as well as for fetal chromosomal abnormalities. We should do CVS sampling between the 9th and 12th week after the patient's last menstrual period. Advantages of CVS: we can get earlier diagnosis of fetal genetic disorders, and then we can have our results 24 to 48 hours after the procedure is done, instead of waiting the 7 to 14 days for the amniocentesis. And then it's also desired for inherited metabolic derangements in the pregnancy, and then it's a very accurate procedure as well. The disadvantages of CVS, though: you can have limb defects. Limb defects are mostly seen in this. The percentage increases with CVS at 10 weeks gestation, either solely or as part of the oromandibular limb hypogenesis syndrome. But studies have shown it's not directly correlated, but it's still, that percentage does increase of limb defects in CVS. You can also have fetal loss, and you can have a false positive result as well, or a false negative. And then there are two methods of CVS sampling. The first is a transcervical technique, and basically we're inserting the needle through the vaginal canal to get to where we need to be, and there we'll take our sample as shown in the picture above with the ultrasound machine on the abdomen, knowing where we're going. The second technique is the transabdominal technique, and the difference between the two is just the location of the needle. The whole procedure is the same. Here you're inserting through the abdomen instead of the vaginal canal, and our transducer is still placed on the mama's belly to see where we're going and to where we get the sample from. So amniocentesis versus CVS. Studies suggest that amniocentesis is the safest and most accurate of the three procedures. CVS, either the transcervical or the transabdominal, it is a higher risk of repeated seizures, and you have maternal cell contamination. You can have sample failures and a higher incidence of a false positive and a false negative result. So it's not as reliable. So just for safety-wise, and the best is amniocentesis. More convenient is CVS, as it's a faster result, but there is a higher risk of it. Now we get into precutaneous umbilical blood sampling, or PUBS. It's also known as choriocentesis, and it occurs at the venous cord insert site. It is used to detect fetal disorders. We can also use color and or power Doppler to assist in the sampling, because we can facilitate the vein insertion into the placenta with the use of that technology. And then for the second trimester, we can gather up to 4 millimeters, and in the third trimester, we can gather up to 6 millimeters. And here in the image shown, you can see they're taking the sample at the umbilical cord insertion site at the placenta to get the necessary blood sample that we need. Now we get into choriocentesis. It's a new technique that involves the ultrasound guided insertion of a needle into the extra amniotic cavity through the vagina from as early as 6 weeks gestation. During the first 10 weeks of pregnancy, chorionic fluid surrounds the amniotic sac. So basically we're able to get a sample that fluid in those first 10 weeks. So we can get as early as 6 or up to 10. This helps investigate early fetal physiology and pathophysiology. However, the only reason why it's not widely used is it's difficult to culture the chorionic cells, and it's a longer process as well. Then we go into fetal tissue sampling. It's similar to blood sampling methods and is restricted to a limited number of tertiary centers. To obtain a diagnosis of a specific enzyme deficit, a fetal liver biopsy under ultrasound guidance helps obtain a tissue sample. So this is just taking a sample from the baby's liver to check if the enzyme and the deficits in that. Now, ultrasighted guided endovaginal procedures. The most common ultrasound-directed endovaginal puncturing procedures are endovaginal oocyte retrieval, ovarian cyst aspiration, biopsy of pelvic masses, drainage of pelvic abscesses, cholecystosynthesis, local treatment of ectopic pregnancies. Now, non-puncturing procedures would be embryo transfer and tubal catheterization, hysterosonography, and hysterosonal pingography, I think that's how you say it, evaluation of the position and displacement of an IUCD, and radiotherapy planning and monitoring. However, in the next few slides, we're just going to go over the few that were most important to the chapter ahead. We're going to focus on cholecystosynthesis. Again, this is a puncturing technique, and it's the presence of fluid in the posterior cul-de-sac, or your PCDS, is easily established by endovaginal ultrasound, but remains difficult to differentiate different types of effusion. So then with cholecystosynthesis, we insert a needle into the PCDS, and it's a simple technique if it is performed safely and accurately with endovaginal ultrasound guidance. Next, we have hysterosonography. It's a non-invasive technique using a slow infusion of sterile saline into the uterine cavity. It helps evaluate abnormalities of the endometrium. And as shown in the picture, you can see you have the transvaginal ultrasound, the transducer going into the vaginal canal, and then with the catheter there, we're inserting the saline into the uterus, and that we can help distinguish if there's any pathology lining that endometrium with that uterus. Next, we have hysterosonosaline pingography, HSG. I'm going to keep it at HSG just to shorten it up. It's an X-ray test to outline the internal shape of the uterus and show whether the fallopian tubes are blocked. In HSG, a thin tube is threaded through the vagina and the cervix, and then you inject a substance known as a contrast material, or a contrast agent is then injected into the uterus, so basically to show the fluorescence and the color that all the to see the fallopian tubes are blocked, and then just the general anatomy and make sure everything's looking good in that. And then here in the picture you can see the syringe and inserting into the vagina, into the cervix to blow up then on the screen how the fallopian tube should look and if any abnormalities or obstructions are occurring in that area. So this was my presentation for chapter 34. I hope you all had information was explained well, and have a good rest of your day. Thank you.